Good afternoon, everyone. My name is Aaron Limbo. I'm the Vice President of Communications and Public Affairs at Hamilton Health Sciences. Welcome to our all-staff town hall for Thursday, December the 17th. We have a number of updates today, actually a lot of content to cover today, and we'll also, as always, leave time for questions and some celebrations at the end. So I'm going to ask our President and CEO, Rob McIsaac, to kick things off. Let us know what we're talking about. So Rob, over to you.
Yeah, so thanks very much, Aaron, and hello everyone. And as always, thanks for joining this week's town hall. It's been another super busy week across all of our sites, and with record-breaking numbers of COVID cases in the province and locally, I think we're acknowledging that there are some very difficult decisions that are likely coming in the days ahead in order to maintain a safe level of care, in order to make sure that our staff are safe in the context of these rising numbers. You should know that leadership is meeting regularly via our formal incident management structure to ensure that we're staying on top of the situation. We're paying close attention to the impact on staff safety, occupancy, and of course, our capacity to continue to deliver scheduled care at the levels we're currently achieving. We're also in constant contact with our partners locally and regionally, all with a view to sustaining hospital-based care for those who need it the most. This week, we also started to move the next cohort of patients to the satellite health facility downtown. Those extra beds are really important for us to maintain flow and our ability to deliver on our full suite of services. Some of you are supporting residents and providers at Grace Villa. I wanted to just extend a very sincere and profound thank you to everybody who's helping out there. You'll hear more about what we're doing and our role at the Villa from Sharon Pearson shortly. Within our walls, we are continuing to manage outbreaks at the Juravinski Hospital. Again, want to offer my sincere appreciation to all the staff and physicians at that site. I think there's some really excellent work that's gone on. And touch wood, we seem to be on a good trajectory, but of course, we'll have to maintain continued vigilance. We've also started to really turn our attention to vaccine availability and distribution. We are planning, albeit in the context of fairly limited information, but we are planning together with public health and others to make sure that we're ready to fulfill a role in vaccination once the vaccine does become available locally. However, just to be clear, and I know everybody knows this, but we have to continue to focus on containing the virus and public health measures. We will take further steps as needed, winding down procedures, halting projects, and recalling staff as needed to make sure people are safe. As I noted last week, we'll be holding town halls more frequently as the situation demands it, to try to keep everyone connected to what is occurring. Please continue to watch for information about our pandemic response through the Daily Dispatch. Just before I turn it over to the other folks who are going to be leading the various topics on this call, I just know we launched the naming of our HIS renewal project, Odyssey, yesterday. And this marks the start of a 2-year, well, not really the start, but the continuation and the naming of a 2-year venture that will get Epic installed at Hamilton Health Sciences, a new electronic platform to manage all of our healthcare data. you should know, we are definitely conscious of the need to balance this important work against the current very challenging conditions that we're facing. I just want to assure you that we will proceed in a measured way. This is a super important move for our organization, and will have transformational impacts on patient safety when it's finished. So, we are balancing competing demands as well as we can. But I do think, this is an important project. We will continue to pursue it as prudently as possible. As always, my personal thanks and that of our board and the executive team to each of you for your unwavering commitment in the context of this very challenging situation. So I will turn it over to Sharon Pearson, our EVP Clinical Operations and Chief Operating Officer, for an update. Sharon?
Great. Thank you, Rob, and good morning, everyone. And I think Rob has, again, nicely set the stage for an update today from an operational perspective. And regardless of where anyone's working in the organization, I think everyone's acutely aware that the sites are all extremely pressured from a capacity perspective, and that our occupancy, particularly at our acute adult sites, is extremely high and has been well over 105% for the last few days. Of course, attributing to that is the increase in the COVID cases. And as, again, Rob mentioned, we have seen record-breaking numbers for ourselves, and we're also seeing that in the community. At HHS, we have 38 cases today. We know we continue to receive cases through the ED, and we continue to work with our partners across the region in providing COVID care. I will say, being part of some of the community groups, there's an immense amount of work happening with our community partners and efforts to support the system. There's a number of groups looking at how we can better support the shelter population and the populations living in congregate settings like residential care facilities, and really working 24/7 to come up with creative strategies. So good work on the part of our partners. And we're also, because of the outbreaks that we have currently at the Juravinski site, relying heavily on St. Joe's and Joe Brandt to help us with the pressures we're experiencing. So extremely thankful for the support that we're getting. We know absolutely this is extremely challenging for our staff and our physicians. We're dealing with the outbreaks. We have a number of staff off needing to quarantine. We have regular seasonal illness right now. And as we know, we are supporting many places in the community. So we are very cognizant of that, very appreciative of the work that staff are doing in efforts to provide the care. And I'll just go to the next slide. We are working with our leaders right now and looking at the need to reduce our scheduled care and care in our outpatient areas. This is, of course, a very difficult decision to make. It's not something we would want to do. It's something that we need to do. HHS, like all of the hospitals in the province, are required to maintain an 85% capacity through the pandemic in order to be able to respond to the surges, and we see those numbers escalating. We also have very stretched, as I just said, health human resources, and we have to be appreciative about our ability to respond in these crisis situations. So work is underway. We have had cancellations. We continue to provide support for those patients most critically in need of scheduled care, and that will continue. In addition, because of the extent of our support in the community, our HHS leaders are working with their respective teams to talk about supporting long-term care and other areas within our own organization, be it related to screening or assessment centers, vaccination processes, et cetera. So again, appreciative for everyone who's responding to those reassignments. And I do understand it's difficult to change your workplace readily, particularly moving outside of the organization. If I could just go to the next slide, because a number of staff are supporting the Grace Villa. And as of today, we do have an operational voluntary management agreement with the Villa. And really what that does is it extends the partnership we already had with them to work in collaboration with them to manage the outbreak. We know this is an extensive outbreak. The home is working extremely hard to try to manage. There are 19 outbreaks in our community right now in long-term care, some of them very substantive. Very dedicated staff, very dedicated physicians in the home, really working endlessly to try to resolve. And with our assistance, we hope that we are moving in the right direction and we're seeing some signals of that. So again, many thanks to everyone who's contributing to the efforts. It's not just clinical staff, we have support services involved as well. Again, if there are those that are interested in volunteering, we do have the address there. And again, always available to talk to anybody about this work or any of the operational issues and questions people have regarding that. So I will hand it over to Erin and happy to take questions later.
Thanks. Sorry there. I was a little slow on my unvideoing. I'm actually not entirely sure who's coming up next in the order. It looks like it's Dr. Michael Stacey, our EVP Academic and Chief Medical Executive, to give us an update on the medical workforce. So Michael, over to you. Thanks.
Yeah, thanks, Aaron. And before just getting into the content on the slides, I just want to echo the comments from both Rob and Sharon, just thanking all staff, physicians and residents for all the work you're all doing at this time. We know it's very challenging for everybody, and we really appreciate the effort that you're all putting in. And certainly hope that over the holiday season, you're able to take a little bit of time for yourselves to be with your friends and loved ones, even if that's only virtually, but certainly take a little bit of a break and refresh yourselves. So just on the medical side, with the changes and the increasing numbers of COVID patients in the hospitals, we are looking at a number of things. And one of them is to look at those redeployment lists that we developed back in March. So that if we do run into physician shortages, particularly in the areas of critical care, emergency medicine, and internal medicine, that we have staff that can come in and assist. I mean, we're not having problems with that at the present, but we do appreciate that if we end up with staff having to self-isolate, that even a small number could mean that we are needing to ask others to step in and help. So medical affairs will be contacting some of those physicians just to make sure they're still able to do that if needed. And Sharon spoke to the regional capacity working group that's really trying to make sure that one site or one hospital system is not overwhelmed with COVID patients while others still have capacity for those COVID patients. And this has helped us, particularly in the outbreaks, with being able to transfer patients coming into the ED with COVID to some of our partner hospitals. And that's been very much appreciated to help us sort of manage through these outbreaks that have occurred at Juravinski. Next slide, thanks, Leslie. And then just so that you're aware, with the increased numbers of COVID patients in both the wards and ICUs, we've been actively with the teams mobilizing additional physician support for these patients. And in particular, with the critical care at both the General and the Juravinski, there have been physicians as of this week staying overnight, so in-house overnight, to support both the patients and also any urgent needs on the wards or in the emergency. And there will be a dedicated Code Blue team. Essentially, that's being covered by that in-house physician at the Juravinski at present, and it'll be a dedicated multidisciplinary team starting next week. So there'll be physicians coming from critical care, from emergency and anesthesia contributing to that. Very much appreciate all of the work that's been done to get that developed by Julian Owen and Corey Sorchak and Bram Rochberg and others who've supported that. So those things will be in place to ensure that there is a safe environment for patients with COVID who need urgent treatment. So with that, I'll hand back to you, Aaron.
Thank you very much, Michael. Next, we're going to have an update from Dr. Dominic Mertz, our Medical Director of Infection Prevention and Control, to take a bird's eye view at what's happening across the country, the province, and our city in terms of COVID. So Dominic, over to you.
Yeah, thanks, Aaron. And I think at this point, I feel like a broken record reporting the same trends every single week. But on the other hand, when you're looking at this picture here, which shows you the national view with cases per 100,000 per week in those black bubbles, but also the RT value. So your trend, you see that several provinces are actually moving into the right direction. These were RT values from yesterday. I would expect that Ontario's back above 1 at this point of time, but at least we were at 0.99 yesterday. So you can see from Saskatchewan, Manitoba, Alberta at 0.96 up to 1 in BC and 1.06, slight increasing trend in Quebec. And in terms of numbers, you can see that BC, Ontario, Nunavut are in that close to 100 range. Hamilton itself currently sitting at roughly 100 as well, and Alberta still with the highest numbers with 258 there. Canada on average is sitting at 123. Next slide. This is our epi curve in Ontario. We had record numbers again today, but more important is what happens with the trend, as I mentioned previously. And it's still, I would say it still continues to slowly creep up, as you can see here. Again, it doesn't look like an exponential increase. So the measures we put in place do something, but they don't do enough to clearly flatten the curve at this point of time. Next slide. These are the number of hospital admissions in the province, and you can see that we are getting closer and closer to peak admissions back during wave 1. ICU admissions also slightly lower than during wave 1, but increasing over time as well. Moving to the Hamilton view here on the next slide. Again, cases per 100,000 per week. We have huge up and downs from day to day based on the way how the data is being reported. But obviously, when you're looking at the trend here, it continues to trend up. I think today we had more than 150 reported, yesterday 40. So on average, we are at around 100 new cases per day currently in Hamilton. Next slide. And these are our hospital admissions, relatively stable since last week. And as I mentioned last week, to a large extent, the increase is obviously triggered by our outbreak patients at the Churwinski in particular. But yeah, we are sitting on average clearly higher than we had been during the first wave, with the exception of the Roslin incident, which increased or more than doubled the number of hospitalized patients from one day to the other. Next slide. These are our unlinked or community cases, which we use, as you know, for our assessment of non-low epi versus low epi. And again, I just reiterating here that whatever's in the gray bar there is not reliable. Next slide. Because most of those cases are not yet categorized into community acquired or outbreak related and so on. But we have never exceeded 15 to 16 in this graph. There's roughly 10% of cases that remain unknown, and we are on the side of caution, consider them as unlinked, and as such have continued to have exceeded the threshold of 20. In Hamilton, we are currently sitting at 26 unlinked cases per 100,000 per week. Halton slightly higher, mostly because they have more unknown cases. Brant and Niagara sitting at around 20, and we don't have enough information at this point of time to what extent that's outbreak related or truly community acquired. Haldimand and Norfolk increasing as well. Peel still sitting at around 60 at this point of time. Thank you. Back to you, Aaron.
Thanks very much, Dominic. Next, another area of planning, a very intense and a rising area of planning that's occurring is around the vaccine and the vaccine distribution. To give us an update on the planning that's underway, which is occurring at different levels, we have Dave McCaig, our EVP Corporate Affairs and CFO, and Leslie Gauthier, our VP Clinical Support Services and Surgery, who are both playing a role in this work. So Dave and Leslie, can you give us a sense of where we're at with this topic?
Sure, just confirming, I don't think Dave has been able to join us at this time. So I'll start, and if Dave joins, he can jump in. So as Aaron's mentioned, there's 3 levels of planning that's happening with respect to Hamilton Health Sciences. So Dave is the co-lead for the regional planning area for the province. There is a second piece of work that is happening with Hamilton Public Health, and Bruce Squires from Children's Hospital is co-leading that with Michelle Baird from the Public Health Department, and really looking at the logistics of a big, I'll say, Hamilton vaccination delivery system and clinic. And then I have the privilege to lead the work for HHS in terms of the Hamilton program and how our hospital is going to support that work. So a tremendous amount of work that is happening at a super fast pace, and lots of information and direction we're taking from the province in that planning. Can I have the next slide, please? So people would have seen a lot of information in the media this week. The province has established 2 centers, which were the pilots, so UHN Toronto and the Ottawa Hospital. Both of those did very small pilot projects, and they now have vaccination clinics up that are seeing about 300, I'm going to refer to as clients. Basically, the population they're serving is the workers in long-term care in their areas. We are planning to receive an allocation in Hamilton. The date at which we're going to receive that allocation is not yet confirmed, but a ton of work is happening to get us ready for when we do receive our vaccines. Probably of real interest to people on the call is who gets the first doses. And the province, with the work of an ethical team, is actually establishing what will be the prioritization in terms of frontline healthcare workers, risks of exposure, vulnerabilities of patient populations. And we're anticipating that we will formally hear from the province within probably by the end of this week, what that framework will look like. So with that, oh, sorry, I've already spoken to this at a high level. The province is giving us very specific information, and is actually being referred to as a clinic in a box. So Michelle Lafleur and our digital team are doing a ton of work around setting things up for vaccination clinics for the city. Essentially, we will have, it's almost like an iPad device that will take care of registration, the screening, the consent, inventory management, and this is being implemented in a standardized way across the province. HHS, we have a number of tables where we are working with the Public Health Department, St. Joseph's Hospital, and our long-term care partners to really work through the Hamilton plan. And as those plans get formalized, we'll be bringing them out to share with the organization. I think I'll quote Dr. Myers this morning and saying, fingers crossed, people are going to start to see a nice Christmas present this year, but date's not yet confirmed. So I'll turn that back over to Aaron.
Thanks very much, Leslie. And I see Dave's joined as well. So maybe we can address that topic a little more during the Q&A, which starts now. As a reminder to all of our participants, I'd point out we have a great record attendance today, almost 400 participants today, which is good to see. Your questions can be asked. You can raise your hand in the participants forum, and we'll call on you to ask your question live. You could also type something into the Q&A function, please. If you can type questions into the question and answer, and then we don't have to look one place for them, and we are happy to address any of those. Maybe I'll start. I know one of the most common topics that's been coming into the question line at hhsnews@hhsc.ca is about the distinction between the 2 types of vaccines. Maybe Dr. Mertz, you have some insight on this, like what is the difference between the product that's currently being rolled out by Pfizer and then the Moderna one that's coming? Is there anything that people should know in particular about that, how that science works or how those things will be administered?
Yeah, in terms of mechanism or technology behind it, they are quite similar. Both are mRNA vaccines. The Pfizer one has the major disadvantage with requiring very deep temperatures, -70 to -80, for transport, which doesn't apply for the other vaccines. So in terms of distribution, that will be much, much easier. And that's the main reason why the current Pfizer vaccine is not being used out in the territories, for example, because it's just too challenges to just get it there. The Oxford vaccine, which might be the next one, but that's probably several months down the road, is a different technology. It's a virus or to which the antigens have been attached. So more your traditional vaccine and not an mRNA vaccine, but not going to be available anytime soon.
Thanks very much for that. I have another question here, question from John about the benefits of the vaccine. Well, those might be obvious to some healthcare workers. Will there be an education about the vaccine for staff to dispel myths and talk about the benefits? I can certainly say, John, we have posted what available resources there are from the province on the hub, but I'm sure that that's a great suggestion. We could go a little further. I don't know, Leslie, is that currently being discussed at the planning table?
So we have a HHS vaccine task force, and on that task force is our pharmacy educator. So it'll be her role to help us work with Erin, your team, and determine information as we get it to share it with everyone. There is an awful lot of information that is coming from the province, and the province again is looking to really provide healthcare workers across the province with some standardized information. So short answer is yes, lots coming, and we'll work to our pharmacy team to help disseminate it.
Good stuff. Thank you very much for that update. I have another question here about expanding EMS supports to help manage the outbreak. So this is, I guess, specific to the outbreak at Juravinski Hospital and Cancer Center. I know a lot of work's been underway there, including EMS supports. I don't know if somebody wanted to expand right now or if that's something that maybe we could best get an answer to you, Leslie, directly through your site leadership about that. Our next question, is it ethical to second a high-risk healthcare worker to frontline care without first offering a vaccine? I don't know if one of my colleagues wants to talk about the ethical process around the vaccine and how those determinations are being made. I know it's certainly a topic of discussion about who gets the vaccine and how healthcare workers fit into that. Leslie, can you offer some context?
Yeah, so I don't know if Andrew Frolick is on the call today, but Andrew is representing HHS in a provincial committee that is looking at an ethical framework to look at who does get the vaccine and in what priority. Again, it's a piece of work the province is really looking for a standardized approach as hospitals and cities roll out the clinics. But we've been told, again, we'll have more information around what does that ethical framework look like by the end of the week. It's coming, and I think if people have any direct concerns or questions, any member of the HHS ethics team have been involved in the work with Andrea, and I think would be happy to respond.
Thanks for that. Another question here, Dr. Mertz, maybe you can offer some perspective given the increasing community spread and the outbreaks, referencing here in particular the Juravinski Hospital and Cancer Center. Is there a plan to routinely swab inpatients? Why or why not?
I guess this question is an evergreen, and I'm not sure how often we discussed this since March. Reality is that universal admission testing would not have prevented those outbreaks based on how what we understand what happened and contributed to this. It's a capacity issue as well, to be honest. And just to make it clear, you may be able to pick up one or the other who's pre-symptomatic at this point of time. You're not going to identify those who are incubating the virus. And this is probably the highest risk group from a hospital perspective. They come in, they are entirely asymptomatic, they would be testing negative and then develop symptoms and become infectious 3, 4, 5, 6, 7, up to 14 days into the hospital admission. So testing, I keep saying we cannot test ourselves out of this pandemic, and testing will not replace proper PPE measures. So the social distancing, the masks, the eye protection when indicated, etc., is our first line of defense. There's one or the other thing we can reduce in terms of risk with testing as far as capacity allows, but universal admission testing is not on the table right now, but something we continue to look into. Maybe there's a potential option with the point of care rapid testing down the road, which is currently being evaluated. So there's certainly work around that happening, but not at this point of time.
And I guess that the next question here in the lineup is about with increasing support for LTC facilities, does it make any sense to test clinical staff more frequently? But I guess the same answer would apply.
The same answer applies, and unfortunately, as everyone can see, the once-weekly testing in long-term care facilities does not prevent long-term care facility outbreaks either. So if that was working perfectly well, I think we would stop other testing and would probably focus on weekly testing of staff. But obviously, it doesn't prevent the outbreaks in long-term care in general. So again, going back to the basics that we have to do on a daily basis, these are key. Testing can help to some extent, but it's not the solution in itself.
Gotcha. Thanks very much. And I just see, thank you, Andrea, for posting some information in the chat forum about the conversation about the ethical framework, and also noting from Sandra Andrzejczyk the opportunity to contact the Office of Ethics at hhsc.ca, which she's posted the address there in the Q&A forum, should you have any other additional questions. So thanks both to Andrea and Sandra for doing that. I have a question here from Lori Isman about staff being redeployed to LTC on a non-voluntary basis. Would there be an executive communication announcing the need for that, and how that might support managers in terms of talking about the decision to do so? Maybe Sharon, you could elaborate a bit on, I know we're taking some steps. Rob issued a note, I think today, alluding to the fact that after the management order that went into place yesterday, we're starting to have some tough decisions about staffing. Can you talk a bit about how that's going to progress?
Yeah, thanks, Aaron. And yes, Rob and Michael and I did issue that today and did indicate the need to look at staffing across all of the demands in and outside of the organization. So again, responding to the need, also responding to the provincial direction that all hospitals have to support long-term care homes in crisis. And certainly it's a very difficult thing to do. We are aware of that. We're trying to work through the processes in the best possible way to support staff so that they can work in other settings and really attend to those that are most in need in our communities right now. So further messaging has happened through the leadership, through the clinical VPs, through to the leadership teams, through to the directors and managers.
Thanks for that. Another question here about face shields. I know this came up in our Q&A box as well, as to why face shields and goggles are not yet mandatory at all sites. Dominic, can you give us some insight on why that might be the case?
It's a moving target, and there will be more communication coming out. Not sure whether today or tomorrow after review by the PP task force. But again, if face shields were the one thing that prevents every single transmission and outbreak, we would have it for weeks and months already, right? Again, it's not. We see outbreaks happening in any setting, whether they have mandatory eye protection or not. What we have proposed from the SME is to say, if you have patients who are unable to mask, and that's another next step that we would like to take, given the newest guidance from public health as well. You would mask the patient. If you have a masked to masked interaction, there's no high risk exposure. That would apply out in the community. We take the same principle into the hospital. If the patient or the essential caregiver or whoever you have contact with is unable to mask or not willing to mask, then there's a role for eye protection. And that's a proposal that we've made, and HHS will come out with new guidance along those lines.
Thank you for that answer. Another question here, I know there's been a lot of work for months now leading up to yesterday's announcement of the full name for Project Odyssey, our hospital information system renewal. I know Rob addressed this in his opening remarks, but maybe Dave McKeag or Michelle Leaflor, if you'd like to expand a bit. The question is, will the escalating COVID-19 situation impact our ability to deliver on that renewal, such an important project? What do you think the implications are?
Maybe Aaron, I could start. Look, it's a very significant project, and we've committed a lot of resource to it, as does every hospital that's going through a hospital information system renewal. And delays in the project tend to represent, impacts to patient safety. They can frequently translate to negative impacts on the project budget. So once you get a project like this going, you would really rather not try to put it on pause, because it has significant downstream effects. That said, if we get into a situation where we need all hands on deck, no project, no area will be accepted from the need to pitch in and support the rest of our team, including the HIS renewal. So I think the short answer is, look, I would rather not have to do that, but I will do it if I have to.
Understood. Thanks. I don't have any additional questions in the queue. Maybe I'll just give a shout out then to anyone that would like to raise a final question. You can do so by raising your hand in the attendees area of the participants section, or you can post something live or in writing here. I have a question here about public health guidelines for isolating are different for the general public than HHS employees. Public health stating that if you have contact with a COVID positive person, regardless of all masking, you must isolate for 14 days. However, staff caring for COVID clients come and go. Could this be where the community spread is coming from? It's a long question. I guess at the heart of it, though, is there a distinction between the isolation policies for the public and for the hospital? Dominic, calling on you again, as this is your area of expertise, if you could maybe shed some light on this.
So my understanding of the question is, why aren't we putting people who work on a COVID unit or who worked on a COVID patient into 14 days of self-isolation, and whether that's the reason why we see community transmission? So first of all, the public health guidance is not that if you had contact with appropriate PPE to be put in self-isolation. So I think that's a very different setting where you walk by or you spend time with someone who's COVID positive and you're not wearing PPE. Of course, you're considered a close contact and at high risk of exposure. But we don't have that situation. We don't talk to people who are COVID positive without the mask and eye protection on. Is it driving community transmission? I think you just need to look at the numbers, right? The number of people who see COVID patients on a regular basis wearing appropriate PPE are simply unable to drive community transmission to the extent that we see out there. So there's so much more going on than those few exposures. And I mean, reality is, other than the one outbreak that we have during wave 1, we haven't seen an outbreak on the COVID unit. We haven't seen an outbreak on the ICU where we are taking care of the COVID patients. So I feel pretty comfortable saying, no, that's definitely not the reason why we see community transmission out there.
Wonderful. Thanks very much for that. I'm going to suggest we move to our celebrations portion of the agenda. I do see one last question here about masking, and as well a comment in the chat forum about masking. We'll endeavor to get a response to those after this meeting and follow up. But in the interest of time, I'm going to suggest we go to the celebrations portion of our agenda. Again, same rules apply. If you'd like to call out someone, you can do so using the chat function this time, or you can raise your hand in the participants box and we'll call on you to give that celebration or that remark on your own. So Rob is here to help me along with this. So here we go, buckle up. Rob, maybe if I could start, I see one from Sandra Lloyd who posted a little midstream through our proceedings today. She had to sign off, but left a really great message for everyone, simply saying a shout out to all of our physicians, leaders, and staff. I'm honored to be a part of HHS. So a nice way to kick things off, I think.
Yeah, very nice. And maybe just to reiterate some of my remarks off the top, maybe a shout out to NRT, who is doing yeoman's work in helping us to shore up Grace Villa and to make sure that we're doing, our part in the community for helping these most vulnerable people. So thank you to the NRT very much.
Any of our additional from our panelists, any shout outs? Sharon, I see you coming up here on the screen.
I mentioned this as well, but St. Joe's and Joseph Brandt have really stepped up in the last couple of weeks to come to the aid of HHS, particularly in GIM, helping with our ED pressures, Joseph Brandt with our fractured hips. And all of these sites are incredibly stretched for staff, dealing with their own outbreaks, dealing with their own COVID. So it really is reflective of everyone trying to acknowledge the unique role that HHS plays in our regional services, not wanting to jeopardize those, and really willing to work as the collective. So to our partners, I'd extend a big thank you.
Awesome, thanks for that.
Aaron, hi, it's Dave. I could jump in with one just to say, it's mid-stride, of course, and we talked about and Les covered the materials about vaccines, but an incredibly complex and huge, very concentrated effort by a lot of very talented people that are putting their all into this across clinical facilities, HITs. So huge thanks to like a very concentrated set of deliverables and goals and trying to get ready for the vaccine here in Hamilton. So thank you to all of that work on top of all the other work that was already being done.
Thanks, Dave. Aaron, a couple of notes here. One from Wendy Sorosky to build on the shout out to NRT. Just would like to call out to the schedulers as well. And then from Michelle Cassidy, thanks to Sue-Ann McAlpine for her leadership of E3 through a very challenging time. Also amazing work by the E3 team who are going above and beyond when they are immensely stretched.
Good stuff. Dr. Stacy, I see you with your hand up, and then I also see we have one of our attendees with their hand up. So why don't we do those two first? Go ahead,
Sure.
Mike.
Yeah, thanks. I just wanted to shout out to the members of the medical affairs team who've really been pivoting every time there's a change and something new needs to be done to support the physician group with COVID. They've willingly taken it on. So, particularly Tanya Roglic, Helen Fagiol, Quinn Kotloff, and Laurie Arbo. I mean, the things change for them just about every other day. So great work on their behalf to step in and do the necessary things. Thank you.
Thanks very much for that. Over to Nicole, one of our attendees, to make a comment. Nicole, please go ahead.
I don't know if Nicole is speaking. She's on mute. There we go.
Go ahead,
Sorry.
Nicole.
I actually wasn't planning on saying anything. Did I accidentally hit a button?
Yeah, but now you have the floor.
I'm sorry, I apologize.
No problem. Well, thanks for that. Okay, so let's keep going in our what we have here in the chat function. Rob, did you want to read out a couple of
Sure. So from Brendan, a shout out to Patient Experience for all their work in supporting clinical areas. Absolutely. Often a very challenging job. So thanks to Patient Experience. From Sasha, celebrating research community, strong investigators, coordinators, nurses and assistants, and a wonderful research administration team supporting this mighty framework. Excellent shout out.
Yeah, good stuff. And here from Cheryl Booker, to all those who are retiring after so many years of service, who aren't getting to celebrate with their coworkers. Thank you. I think that's a great message too. I know we have a couple of retirements announced, and it's not a great time for that in terms of celebration. So thanks for recognizing that. Also from Leslie Gauthier, thanks to individuals across HHS who are organizing Christmas donations for those in the Hamilton community and in need. Thanks very much for that, Les. Merry Christmas. Celebrating the infection control team at Juravinski who are working around the clock to support our units and teams, from Michelle Cassidy.
Yeah, hard to say enough about all the great work that's gone on at Juravinski relative to the outbreak. It's such a hugely trying situation. And so I think we can be really proud of the work that the team there has done.
I think we have another one here in the chat forum, Rob, if you want to go ahead.
Yeah, sure. So from Andrea Frolic, so many people have inspired me this week. The NRT teams at all sites and Grace Villa providing extraordinary care in extraordinary circumstances, staff and physicians at E3 who pivoted so quickly and courageously. The COVID unit on 5 West, providing wonderful care to so many. The psycho-spiritual care, resilience and ethics teams, helping people navigate complex emotional and ethical issues in tough circumstances. Your courage makes me stronger. Thanks, Andrea.
Good stuff. There's a couple in the question forum here too. Congratulations to the many members of the HIS project, now Project Odyssey, who have passed projects and exams in the last couple of weeks, getting ready to move forward with the build and implementation. That's from one of our team members. Thanks for that. And from Patrice here, Patrice Cloutier, recognizing the members of the PPE task force, leaders, IPAC, educators, and all the others that deal with complex issues and endeavor to give quick answers to these very important questions from staff and physicians on this topic to ensure their safety and well-being. Thanks for that, Patrice.
Yeah, another one, Aaron, from well, not sure who it's from, but the outpatient area at the JCC opens its doors at 8 a.m., but appointments are scheduled at 8 a.m., so people are often coming early this morning. People are waiting outside, it's too cold. Okay, so it might not be a shout out, but a comment about maybe something we can look into and try to remedy.
Good stuff. Okay, well, one last call for any shout outs. It looks like we're nearing the end of our agenda, Rob. Why don't I let you close us out? And to those, I did see a couple of questions there at the end that popped up once we ended our Q&A. Of course, we'll make sure we get answers to those people and post information on the hub where we can. And you can always send us questions in advance at hhsnews@hhsc.ca. So thanks.
Okay, thanks, Aaron. Maybe just close with a bit of information. So this holiday season, we know that staff, physician, and residents will engage in lots of different celebrations that are meaningful for them and for their families. We have a very diverse staff community and physician community. I know this year will be challenging and we'll have to change how we do things compared to previous years, but I still want to say my best wishes to everyone as you mark whatever celebrations you might be engaging in over the coming weeks. And again, say thank you just to acknowledge everyone for their extraordinary efforts this year, which I'm super proud of, and I'm recognizing those who will be here over the holidays. We have arranged for some complimentary beverages and treats for HHS team members. We'll be providing details about that later this month so that you know how to access it. But we've been able to do that with some help from a generous donation, and we are going to be making that available to everybody at Hamilton Health Sciences. So I know it's a modest bit of recognition, but recognition nonetheless, to express our gratitude for all the hard work that's gone on over this past year. So thank you, everybody. Aaron, back to you.
Thanks, Rob. Okay, so we'll close it out for today. Thanks to everyone for taking time to participate. We'll continue to hold town halls as often as is needed, as the information keeps coming in that we need to get out to everybody. We had bi-weekly kind of cadence before. We have had weekly right now. I think it's on an wait and see basis over the next little while, but you can always, you'll find out on the hub. We'll try to promote at least 3 or 4 days in advance. So please look to that and attend these as your schedule permits. And as always, your questions are welcome in between those sessions. So until we speak again, stay safe. Bye-bye.